Good afternoon, everyone. And I will be first thanking Dr. Rohit for making me part of his IC. Today, I'll be talking about amblyopia, some old and some new concepts. How do we have moved beyond patches? So, as we all know, amblyopia is basically unilateral or bilateral deprivation of vision because of either sensory lack of sensory stimulus or abnormal binocular interaction, for which no organic cause can be detected, and if treated on time, it is reversible. So it can be classified as strabismic amblyopia, which is more common with esotropias as compared to exotropia. Ametropic amblyopia is seen whenever there is bilateral high refractive error in both eyes. And isometropia is basically difference of refractive error in between two eyes. And visual deprivation amblyopia is the one where you have the understimulation of retina, like in cases of congenital ptosis, congenital cataracts, or congenital corneal opacities. So, early identification, proper evaluation, and timely intervention is critical for the management of amblyopia because of the cortical plasticity, which is there only in critical age. And that depends on number of factors like age of patient, duration of low vision, type of refractive error, quantity of refractive error, also the type of amblyopia. Generally, the anisometropic amblyopia tend to do better as compared to strabismic or sensory deprivation amblyopia. And the most important key factor is patient compliance. So the basic management of amblyopia still remains the same. Identify the cause of visual loss, correct adequately for the refractive error, give preferential stimulation to the amblyopic eye, and the goal is to achieve the equal vision in each eye. But now, as more and more focus is there on binocularity, so not just achieving equal vision, we also now want to have some that patient should gain some amount of binocularity as well. So, optical correction still remains the standard therapy. Occlusion therapy is again a gold standard as far as amblyopia management is concerned. Penalization, active vision therapy, pharmacotherapy all are the part of amblyopia therapy for different spectrum and type of amblyopia. But what is more important now is that as advances in technology is coming up, we have now moved on to active vision therapy, which was there earlier also, but has now become a kind of a routine in clinical practice. So, optimal optical correction can never be overemphasized, is the first step of amblyopia therapy. It removes the image blur and gives a patient a sharp image, which is very important for stimulation of retina. So there have been American Academy guidelines, but now we have our own guidelines and national consensus guidelines, which have been published by AIOC and are also published in IJO. That these are the factors, or this is the amount of refractive error which we need to beyond which we need to give patient refractive correction. They are readily available on the net or on IGO. The number two is occlusion therapy, and it still remains the gold standard. Whether you have to do a partial occlusion or a full time occlusion, that is not important. But what is important is that the patient compliance. Even if it's a part time occlusion, we have to make sure that patient is doing it for these prescribed hours which are necessary. It not only helps in anisometropic amblyopia but also in strabismic amblyopia. Maintenance of occlusion is again important. So once the equal vision has achieved, it's not that we will abruptly stop the occlusion. One has to taper it over the time, and it has been seen that the patients who have for whom the occlusion therapy has been stopped abruptly recur more frequently as compared to the patients for whom there has been a tapering of occlusion dose. Recurrence rate again in these cases is very high, and we have factors like old age, onset of treatment, larger visual recovery, better best corrected visual acuity after the treatment. All these factors are related to more recurrence of amblyopia. Penalization, which can be optical or pharmacological, again is an alternative therapy, but we need to remember that it does not work in all cases. It may not be so suitable if the amblyopia is severe enough, or if the vision is less than 6 by 60, because any amount of penalization is not going to decrease vision in the normal eye beyond 6 by 60. So it is reserved only for mild cases of amblyopia. Pharmacotherapy, both levodopa, citicoline have been tried, but with not so great results. There have been reports where some improvement is seen, but the effect is temporary as far as the drug continues. But once you stop the drug, there is a possibility that this may recur, and of course, there are systemic side effects of both of them. So, what is more commonly used up now, or what is kind of emerging, is active vision therapy. It's an age-old concept. It was also given earlier in form of near vision task, hand-eye coordination, and all such things. But because of the development of the technology, we now have software, so that attracts children, that makes them more attractive towards more, engages them more, and they can continue playing video games, and which is a fun activity for them. So it's basically the reteaching to the visual pathway again, about the hand-eye coordination and visual motor interactions in a very playway method. So it can be monocular video games, so one eye patch and patient can play video games, or it can be dioptic. So more and more dioptic therapies coming up, which is based on virtual reality or software based, where the normal eye is given some disadvantage, either in form of decreased contrast, or different eyes may have different colors to dissociate them, where the amblyopic eye gets the advantage over the normal eye, and patient is asked to is forced to use the amblyopic eye to play the game. However, all these therapies have their own limitations. After some time, children do get bored of it, and sometimes if children are too young, like 2 years or 3 years old, they may not be so readily willing to play these games, or they may not be even able to comprehend these games. So for young children less than 5 years, probably occlusion still is the gold standard, while older children, you may try dioptic therapy. And also you have to keep in mind that after some point of time it becomes very monotonous, and child may lose interest, so that monitoring is also necessary with these kind of therapies. So to sum up, management of amblyopia, the first and the important thing is to rule out any other organic cause of loss of vision. Second most important step is to do proper cycloplegic refraction and give optimal correction, which is necessary for that age group and for that refractive error, depending on whether there is squint or no squint. For anisometropic amblyopia, again, it's the constant use of glasses, followed by either conventional occlusion or active vision therapy, whatever is convenient for the patient and whatever makes patient more compliant. For ametropic amblyopia, the standard of therapy is still correction of refractive error, and occlusion there probably has no role. Regular follow-up, reassessment, maintenance therapy, ensuring compliance is what is more important as far as amblyopia therapy is concerned. Thank you.
Thank you, Dr. Swati, bringing us up to date with the changes in management of amblyopia.